Welcome everyone to the Baltimore County Fire Department EMS Academy training on this lovely Wednesday night. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU provider at Johns Hopkins. I am an active member of Pikesville Volunteer Fire Company, and I have the honor of serving as an associate medical director with Baltimore County Fire Department. On behalf of Dr. Pollack in the medical director's office, on behalf of the EMS office, Director Shenning, Captain Willits, Captain Stewart, Captain Nats, thank you so much for everything that you do. Thank you for your dedication to lifelong learning. A big shout out to Ashley Brooks, who's online. She is helping us to run this Zoom. Thank you for that. A couple of thoughts on Zoom in terms of navigating this platform if you're new, and to try to make this as smooth as possible. In the upper right-hand side of the platform is a speaker view or a gallery view. I encourage you to use the speaker view. That way, the speaker will come into focus. As you go around to your left and down to the bottom left of the platform, there is a mute button. I encourage you to mute yourself. You're welcome to unmute if you have a question towards the end for sure. But for now, I encourage you to mute. So we can go ahead and practice that now by clicking that mute button. Over on the right-hand side also, or down towards the bottom of the platform, I'm so sorry, in the middle is a chat function. I would encourage you to open that chat function, and then that box will show up on the right. That chat function is a place where Ashley will be sending out a link for attendance. If you want your CEUs, please keep an eye out on the chat for that link to an Excel file where you can enter your information. If you are a career department watching this as a group, please reach out to Captain Stewart, who will organize your CEUs. Yeah, I think that's about it. Great. So tonight we're super excited to have two physicians who are going to be talking a little bit more about optimal care in COVID. Dr. Matt Levy is his career in EMS spans over 25 years and began as an EMS provider. He is an associate professor and holds a leadership role in the Division of Special Operations at the Department of Emergency Medicine at Johns Hopkins University School of Medicine. He completed residency and was a chief resident in the Hopkins School of Medicine. He's a member of the EMS Fellowship faculty at Hopkins. Dr. Levy maintains an active role in a variety of local, state, federal, and international elements related to emergency medical, tactical, and disaster care. Dr. Asa M is an assistant professor in the Division of Special Operations at the Department of Emergency Medicine, Johns Hopkins University School of Medicine. He completed residency and fellowship and was a chief resident at Hopkins University. He's currently program director for the EMS Fellowship at Hopkins. He also continues to work as a medical officer within the Center for Law Enforcement Medicine at Johns Hopkins. Gentlemen, thank you so much for being so generous with your time and expertise.
Well, good evening, everybody. And Sean, thank you so much for that warm welcome. And it's really a pleasure to spend some time this evening with everybody. We know that time is incredibly precious, and we're going to try to make the most of the next hour or so by going through some questions and answers. Asa is also online, and Asa, I'll turn it over to you for some, if you want to say anything while I'm going to start to try to load the slides here. So bear with me, everyone.
Great. Yeah, thanks so much for that introduction. It's really a pleasure to be with all of you. It's a great opportunity for us, as Matt said, to be able to interact with our pre-hospital clinicians. You know, both Matt and I started our career in EMS. We have a strong connection to EMS, and this is really what we love to do. So any opportunity we have to be able to participate in EMS clinician education is a great opportunity for us. So thank you all for having us this evening, and hopefully you'll find this useful.
Very well said, Asa. And you know, as EMS physicians and medical directors, and both of us being 20-year plus paramedics, we consider ourselves pre-hospital personnel who went to medical school, and we like to think about our approach to problems that way. We like to think about our approach to complex situations in the very practical and pragmatic manner that we do in EMS. So we all know the world is very different than it was just a few short months ago, thanks to this element, this disease process we call COVID-19. We've assembled a list of a couple of questions. We'll get through as many of them as we can in the hour. Top questions that we've been asked, that we've been answering, and information we've been providing for everyone. So let's just jump right on into it. Perhaps first and foremost and most important is that I go too fast. How about most importantly for us is that you guys know that the information we're presenting is evolving. All right, so first and foremost, it's evolving, and it's evolving quickly. So it's current as of today. In fact, I will share with you that just this afternoon, Asa and I were updating our slides because some of the CDC stuff has changed as recently as in the past few days for this. Likewise, any opinion that we convey here, any information we give, those are our opinions and coming from us, and don't represent any agency or organization that we belong to. And this is summary material. This is not comprehensive material. We're going to treetop this as much as we can and give you the big pieces that we think you need to know or be familiar with as EMS clinicians. And lastly, what we're saying here is not meant to stir controversy or to directly contradict official guidance from any organization that you may be part of. Your agency leadership, our agency leadership, and or medical directors should be the definitive source of information for your organization. Okay, now that all of that is out of the way, let's talk a little bit about COVID. So, Asa, I'm going to let you take this first one, but we got this question a couple of times because coronavirus is not new. How many coronaviruses are there out there, and what do we know about them?
Yeah, great, Matt. Thanks. And just so everybody knows, the general outline of how we approach these questions is we're going to start with some just general background information about the virus. We're then going to sort of proceed into best practices for PPE, including donning and doffing, and what to do in terms of ambulance decon. We're then going to move into clinical presentation of patients with the virus, and then sort of get into methods of management, therapeutics, and ultimately end with some more evolving information, particularly in regards to pediatrics. So, yep, the first question, how many coronaviruses are there? So really prior to the discovery and the global outbreak of SARS-CoV-1, so SARS is how we knew it beforehand in 2003, only the human coronavirus 229E and OC43 were the only two coronaviruses known to infect humans. However, following the SARS-CoV-1 outbreak again in 2003, there have been 5 additional coronaviruses discovered in humans. And again, most recently, this novel coronavirus, which we now know as SARS-CoV-2. And just as a point for terminology, the virus is SARS-CoV-2, the disease it causes, and the clinical manifestations is what we refer to as COVID-19. So moving on to the next slide, I think is a really interesting graphic representation of where COVID or SARS-CoV-2 fits in with other viruses that we have seen throughout history. This slide, as it talks about in the graph on the bottom, looks at case fatality rate and transmission, with the important point that obviously this is all still evolving. And this slide has the case fatality rate around 3%, obviously depending on the literature and the data you look at. Some of it shows that to be up to 5% now. But again, with that said, it's still sort of very interesting to look at how this virus compares to others. So you could see in terms of transmissibility, it's not as infectious as things like measles or chickenpox or even smallpox. And it's not as deadly, and it doesn't have as high as a case fatality rate as some of the other SARS viruses that we've seen, including, or the other coronaviruses that we've seen, including SARS-CoV-1 in 2003 and the MERS virus, which you guys see up on the top left-hand side of your screen. Also, in comparison to the bird flu, which is the H5N1 virus, certainly not as deadly, but also not quite as easily spread. Then another comparison that we all like to make is to the seasonal flu. So you could see, looking at SARS-CoV-2 or coronavirus that we're talking about now in comparison to our seasonal flu, it's really neither as infectious or has the same case fatality rate as does our seasonal flu, which I think nowadays everybody is really sort of catching on to. So hopefully that gives you guys a good overview of how many coronaviruses there are and where the current coronavirus or SARS-CoV-2 sort of fits among other viruses that we have seen. Matt, I'll transition it off to you for the next question.
Great, thanks, Asa. So one of the next most frequent questions that we were getting earlier on that may become more common knowledge now is just how contagious is SARS-CoV-2, right? Because when we talk about the impact that an illness like this can have, or a virus like this can have on a population, one of the things is how contagious it is. Well, indeed, SARS-CoV-2 is actually fairly contagious. And you may have heard of this term in the mainstream literature. R0 is what it's referring to, which is a factor, which is the infectivity factor, basically saying how many people, other than the one person who's sick, is likely to be infected. So when we look at a disease like SARS-CoV-2, the thought is that the infectivity, the R0, is somewhere between 2 to 3.1. And so for every one person that is infected, that person is likely to infect as many as 3 people. And it's that amplification phenomena that had so many people worried and is helping to drive some of the mitigation and preparedness methods that we have now had to adapt as basic, normal, everyday functioning, which we'll talk about. How does this compare to some other infectious diseases that you may be familiar with? Well, Ebola was one that was on our mind not very long ago. Ebola has an R0 of 2. The seasonal flu has an R0 of about 1.3. Interestingly enough, other more infectious things, measles. If you guys remember, just last year, we had a real concern about measles in the community. Because for every one person who's infected with measles, that person can infect up to 11 to 18 people. So what's the variance here? What's different? Well, a lot of it has to do with how stuff is spread and how the illness is spread from person to person. But for the purposes of SARS-CoV-2, that you can now appreciate part of the reason why both public health and public leadership personnel are so concerned about its ability to decimate and to spread so quickly. By the way, some sombering news, if you haven't heard, today officially we did pass that 100,000 mark for deaths in the U.S. So this is definitely, and that's in the matter of a few months. So let's keep moving along. Asa, I'm going to turn it back over to you here for our next question, which has to do with flattening the curve. Take us through it.
Yep, so this is a term that we've heard really early on, sort of coinciding with when we started hearing about the coronavirus. And, you know, the concept of flattening the curve is really not unique to COVID. It's really a public health strategy that has been around and been utilized many times over. So the curve that's being flattened that we're referring to is the epidemic curve. It's a visual representation of the number of infected people needing healthcare over a period of time. So during an epidemic, a healthcare system could break down when the number of infected people exceeds that healthcare system's capacity to take care of them. So flattening the curve means slowing the spread of the epidemic so that the peak number of people requiring care at a time is reduced. And therefore, you're not going to overwhelm that healthcare system. So it is critically important that all of these steps that we've been hearing about and that we've been enforcing, the social distancing, the mask wearing, the appropriate PPE, the hand washing, all of that stuff goes into helping to flatten this curve. Because if you see on the left of that graph, if we peaked at a certain capacity, it would surely overwhelm our healthcare system, and many more people would die because we just wouldn't have the space, the equipment, the providers, the therapeutics to be able to take care of them. So that's why this concept of flattening the curve is so critically important.
Thanks, Asa. That was great. And I think all we have to do is look to the experience and the tragedy that unfolded in New York, that unfolded in northern Italy and other places around the world, and you can see how quickly things can spiral out of control and how quickly that peak that you described can exceed the capacity of the healthcare system. And as we'll talk about later on, the patients who need hospitalization tend to be awfully sick. And so the ability to build capacity is a really important thing here. Flattening the curve buys us that time. We're going to keep moving along, and the next thing we're going to talk about are PPE and best practice recommendations. And by now, many people, if you're actively functioning as an EMS clinician, have gotten used to the current battle rhythm of PPE. But for all patient encounters, all the time, it should be a simple face mask. Now, I know in Baltimore County we're using N95s. That's super fantastic that the leadership in the department has the ability to provide us that degree of depth. It really is wonderful. But at a minimum, a simple face mask, eye protection, or face shield and gloves. All patients, all the time. Why is that? Well, one of the things that we know is happening is this situation that we call asymptomatic spread, where people look fine and they don't have symptoms. And they look fine, they don't have symptoms, then 48 hours later, they have symptoms. And they were actively shedding virus during that time. So the only way we can slow that spread and flatten that curve is to protect ourselves by wearing this type of PPE. So that's all patients all the time. When we're dealing with a PUI, a person under investigation, at a minimum it's an N95 for the face mask plus the other PPE, including a gown. Now, one of the things, as I mentioned earlier on in our disclaimer, we're going to give you our opinion on some of this stuff. And one of our opinions is that if you're going to be wearing one pair of gloves, you might want to consider putting on a second pair of gloves. That's a departure from what CDC says or the health community, the health departments locally. And our rationale in EMS is we know what happens with gloves is we're putting them on and off. And we know sometimes taking off that outer layer glove, having an inner layer glove to help protect you. So that's a personal preference, but that is not an official recommendation that you will see coming out through the recommendation bodies. Couple more thoughts for you here. Please remember this, your patients, our patients, if we have a PUI, they need to be masked as well. But PUIs, the patients themselves, they don't get N95 masks. They get a simple face mask. In working clinically in the emergency department, we have people coming in wearing N95 masks, and sometimes they're wearing the N95 mask that has the exhalation valve. So what are they doing? Are they actively, they're protecting themselves, but they're not protecting anyone else around them because that exhalation valve is a direct output conduit and is allowing exhaled particles to come out. So the PUI should be wearing a simple face mask, and especially if we're going to be giving oxygen on top of that, put that simple face mask over top of the non-rebreather or over top of the nasal cannula. Couple other thoughts for you. Cloth masks that we have that are being advocated to be worn in everyday society, non-surgical face masks, but cloth masks, those are not a substitute for a surgical mask. And so don't wear your cloth mask that you would be wearing in the fire station or wearing to go out to get groceries or wearing on a pub ed detail. Don't wear that on a call with a patient because it's not the same level of protection. If we run into a scenario, and this is important to note, if we run into a scenario in the weeks and months to come where we deplete N95s, you may see a recommendation for simple face masks. And in fact, the guidance documents that are out there throughout the state do actually make mention of this already, that simple face masks can be substituted for N95s until the chain is restored. But we've been pretty fortunate in the central Maryland, Baltimore County area that we haven't had to go to that length. Some other general practices, we want to limit the number of people who are at patient's side and within that 6-foot window or envelope around the patient when at all possible. Not only do we want to limit the number of clinicians and EMS personnel, we want to limit the amount of equipment we're taking into that zone because we want to minimize contamination. A great thing to do when practical and safe is have the patient come outside to you. If we can get into an environment where we can have a higher rate of air exchange, especially like being outside, then we can really, really decrease the safety, the exposure risk to our personnel. I think everyone knows this by now, but transporting friends and family is a no-no. We're not doing it. They're not even going to be allowed in the hospital. The exception, of course, is a minor. and it would be a minor or a special needs adult who needs that adult person, that other person with them to help manage the situation. There are exceptions like that, but in general, the position of taking family members along to the hospital, that's been paused, and actually when they get to the hospital, they're not letting them in. Many of us have experienced that in our operational and clinical worlds. I'm going to turn it back over to Asa, where I'd like you to we're going to go through some best practice considerations for donning and doffing, because we know this is a really big deal, and this is a way where EMS clinicians get themselves in trouble, is when they're doffing this gear and taking it off. So Asa?
Absolutely. Great introduction. You know, we have done really well, at least in my opinion, with our PPE and maintaining our vigilance when putting on our PPE. I think in some cases, we need to remember that you have to maintain even higher level of vigilance when donning and especially doffing this PPE. Because as Matt just alluded to, it's in the doffing process where many clinicians become sort of inadvertently contaminated when taking off this gear. So starting with the donning process, I'll just have Matt just advance the slide, so we'll take a look at the first set of pictures. So as you guys can see here, the first thing everybody wants to do is, you know, if you have access to soap and water, which clearly we don't in the field, you wash your hands, otherwise you Purell. You then put on your fit-tested N95 respirator, and if you're doing the 2 pair of gloves, you put on your initial pair of gloves, followed by your contact isolation gown. At that point, you're going to place your face shield on or your goggles, obviously ensuring that your goggles securely fit around your eyes and there is no sort of break in that area. And then you would put on your second pair of gloves, and at that point, you're ready for contact with the patient. When it comes time to doffing the gear, again, this is where it is really, really important that we make sure that we maintain the exact same steps every time. And one thing that we have utilized, at least within my critical care program at Hopkins, is we have introduced a safety officer. And the purpose of the safety officer is purely to watch the other team members don and doff the gear. They are also either an EMT, a paramedic, or a critical care nurse, but in that role of safety officer for that particular patient encounter, they are not doing any patient care whatsoever. They are just there to observe donning and observe doffing and make sure that we maintain strict precautions. And I believe personally that that has led to a 0 exposure rate of our clinicians in Lifeline right now. We have done and have not had 1 exposure, and I attribute in large part to the donning and doffing techniques in the presence of that safety officer. Okay, so moving on to doffing, Matt, I'll just have you bring those set of slides up. So as you see, first, you're removing your outer layer of gloves, and a good practice to remember is every time you do a step, you should Purell your hands. So before you even remove that layer, you Purell your hands, then you remove that outer layer of gloves. As you go to remove your gown, an important step also is, as you could see in that picture, labeled as number 2 in the doffing steps, you're crossing your arms. So you're grabbing the opposite shoulder with the opposite arm and you're pulling forward. And as you're pulling forward, you're rolling the gown into a ball in front of you, being very careful not to let it, you know, contaminate you or drag against any sort of other material that you have in front of you. Again, at that point, because you did another step, you're going to Purell. You then can remove your face shield. You're going to Purell. You're going to remove your mask. You're going to Purell for the last time, or you're going to wash your hands with soap and water. So again, in summary, maintaining vigilance with this process, making sure every step is done every time, making sure you Purell between each step, and having somebody that could take the place of the safety officer is quite helpful. And Matt, I'll turn it over to you for the next question.
Great, thanks, Asa. And we recognize that for some, this may be a review. For some, it may be new information, and that's why we're going through it. But hopefully you'll take away some best practice steps from this stuff. Let's move along here and let's talk for a moment about ambulance decontamination in terms of best practices. Well, first and foremost, leaving those rear doors open when you're parked and at the hospital, just to put that qualifier in there, of course, to allow for sufficient air exchange is really important. We got to get the air rate to be turned over. In fact, our goal is to really ensure that there is, while we are offloading the patient and inside, allowing the cabin air in the back of the ambulance to recirculate, to be refreshed and changed out. There is a unit that's called the ACH, or the air changes per hour, and that's a function that's actually been studied well by the industrial hygienists. And there's a specific time required for airborne contaminant removal. And there's very clear CDC guidance for this stuff, and that guidance has been used by the leadership from all of our organizations to help create and establish the practices for decon that we're using. But remember this, when you're actually in the back of the unit doing the decon, you should be wearing protection as well during that time. Not just because you're in that environment, you're also working with cleaning chemicals, but you want to make sure you're wearing a face shield and either eye pro or goggles or face mask, as well as gown and gloves. Regarding the actual agent to be used to disinfect that's effective against SARS-CoV-2, well, there is an entire list on the EPA website that lists out the different chemicals and what can and cannot be used. A bleach water solution is effective, but there are a number of commercial hospital-grade disinfectants that are also effective against this virus. There are, however, a few that are not. And so be assured that the ones that the organizations that are being put out by the agencies meet the criteria for an effective unit, an effective decontamination product. The takeaway here is don't improvise it. Don't assume if you ran out of something, any cleaner will be good, because there are ones that are approved on the list. Now, what do we wipe down? Well, the rule of thumb is all surfaces that may have come in contact with the patient or materials contaminated with during patient care should be thoroughly cleaned and disinfected and allowed for the time for that to dry. And this stuff takes time, as we all know. This is not an instant process, but a thorough wipe down does take some time, and it's important that there's good process in place, because it's going to be one of the only ways that we're going to prevent inadvertent secondary contamination or cross spread. So that was just a quick review of some ambulance decontamination stuff. Next, we're going to go into a little bit about how we handle the situation of using PPE over and over again. Asa, I'll turn this back to you.
Yep, great, thanks. So this is a question that we have been asked a number of times, and definitions which sometimes are used interchangeably but actually have different meanings. So the first thing is extended use. So extended use refers to when a mask is worn to see multiple patients without removing that mask. The next is reuse. So again, this is different. This is when the mask is doffed and then donned again in between patient encounters. So extended use tends to be something that we do in the hospital, right? So when we go out of a patient's room, we'll take our gown and gloves off and decon and wash and Purell. And then when we go to see another patient, we'll be using that same mask, put another isolation gown on, obviously another set of gloves, Purell our hands or wash our hands in between, but it tends to be that same mask that we wear. For our EMS clinicians, we don't tend to do this. We do basically reuse, where we doff the mask and then we redon the mask for our next patient encounter. Another sort of question that is often asked is, how many times can I use the mask? Well, there's really no way to determine the safe number of reuses for a mask. But the things that definitely hold true is that it can't have any visible soil on the mask. If the mask is visibly soiled, you got to throw it away. If the mask is wet, so don't take like product and start wiping the mask and getting it wet, because at that point it can't be used either. So if there's any concern that the mask has been soiled, you should take that mask off, throw it away, and reuse a different mask, or I should say use a different mask for your next encounter. And then again, whether you're doing extended use, again, primarily in the hospital setting, reuse in the pre-hospital setting, you must ensure that that mask continues to maintain its fit in form and seal. Something that sometimes you will see clinicians over their N95 wear a surgical mask. So that may also protect that N95 from getting visibly soiled, and that surgical mask that is sometimes worn over the N95 also has a face shield on it as well. So it sort of serves two purposes with respect to that. So that is the difference between extended use and reuse. Again, making sure that no matter what definition you're using, if the mask is soiled, you throw it away, and then the mask always continues to maintain its fit and form. And if it doesn't, you need to find a new mask. Matt, turn it back over to you.
Thanks, Asa. And one of the things I wanted to touch on for everybody is you may have heard about the process that's being used by the state to clean masks, to clean N95 masks. And that process is the Patel process, where the masks are being collected and they are being run through a hydrogen peroxide type system, and then those masks then be returned. I just wanted to touch on that because they're using many of the same principles that Asa talked about here, which is if the mask, upon their receipt, if the mask is visibly soiled or not functional or won't maintain its form, it's getting discarded. It's not even getting cleaned. Same thing for the elastic straps. Those are the most likely part of the mask that will break first. So what's currently being done with the Patel system is those masks that are being cleaned, they're not being reintroduced back into the PPE supply chain at this point in the county yet. What they are doing is we're keeping those and maintaining that supply should we ever get to a critical situation where there are no more masks to be had. So I just wanted to touch on that very quickly. Again, great summary, Asa, on extended versus reuse of masks. So this is a question that we continue to get, and as medical directors can be somewhat challenging because sometimes we find out after the fact that due to something happening, someone wasn't wearing the PPE that we hope they would be wearing, or a circumstance happened really quick where there was a piece of PPE came off. And the question is, what constitutes an exposure to SARS-CoV-2? So let's try to unpack this a little bit. The first thing I want to do is introduce the term prolonged close contact. Now, the CDC had used the term prolonged close contact, meaning greater than 5 minutes and within the 6-foot radius of that suspected COVID-19 person without appropriate PPE. So if you're wearing the appropriate PPE and you are doing patient care and you're wearing the PPE you've already described, it's not considered an exposure. That's the whole point. That's the point behind wearing the mask on every call, everybody. That's the point behind doing the things that we're doing. Now, just a point of note, the 5-minute window here was recently extended by CDC to around 15 minutes. However, current institutional and organizational practice in our part of the state and the region is still to use 5 minutes out of an abundance of protection to the clinician. Okay, what are other examples of exposure? Well, performing, any airway or respiratory procedure without appropriate PPE. What could that be? Intubation, nebulization, CPAP, O2 administration, or direct contact with the respiratory secretions. Without getting too graphic, you can imagine the unpleasant experience that might be. But let's agree that the safest way for us to protect ourselves is to be wearing that PPE ahead of time. And one of the things we can do to significantly decrease the risk to our personnel and to our crews and to our shift mates and to our families is be extra cautious about how we're operating and being conscientious of the fact that when we get within a certain distance of a person, we should be in PPE. So with that being said, I'm going to turn this next question over to Asa. I think the next question has to do with returning to work and how do we handle that. And we're going to just give you some brief overview on that. So Asa, I'll let you take it away.
Great, thanks. So when we discuss EMS clinicians or clinicians in general returning to work, we talk usually about two different strategies. The first strategy is a non-test-based strategy, and the second strategy is a test-based strategy. So the non-test-based strategy, looking at that first, so basically the individual has to have 10 days from the onset of symptoms and at least 72 hours needed to have passed since the resolution of fever and there is improvement in respiratory symptoms, for example, cough. When we talk about test-based strategy, so here you've had, again, resolution of fever and improvement of symptoms, and at this point, you're tested again, and you need to have 2 negative tests that are greater than 24 hours apart. You will see that this sometimes varies, and some agencies will use 48 hours apart. So as you can see on the bottom, this is a particular important thing to remember, that you should always be following your agency's specific policies and guidance on this, because certainly this return to work question can vary from agency to agency and from jurisdiction to jurisdiction. So again, non-test-based strategy uses symptom improvement, again, greater than 10 days from onset with at least 72 hours since resolution of fever and improvement of symptoms. And the test-based strategy, you have to be getting better and have 2 negative tests separated by at least 24 hours. So hopefully that's helpful to sort of unpack that. And I'll send it back over to you, Matt, for the next question, which looks at our symptoms and clinical presentation of those with COVID.
Great. Well, thank you, Asa. So I think people are generally familiar with with many of the common signs and symptoms, which would be the fever, the shortness of breath, and the cough, and a new loss of taste or smell. Those are the common ones, but you can see some of the other ones that are still on there that should raise your suspicion for someone as a PUI: myalgias or body aches, sore throat, diarrhea, chills. Could be fever or the feeling of having had a fever, headache, and repeated shaking with chills. Sometimes we call that rigering. Those are your common symptoms. When we look at the breakdown of these signs and symptoms of patients admitted to the hospital, you can see the vast majority have fever and or cough. But fatigue and myalgia is another one of these. Now, this is a real challenge because I've yet to meet a healthcare colleague right now who doesn't have some degree of fatigue. Right, so understanding what is new or different versus part of a bigger picture is really important, and paying attention to how you're feeling is important as well right now. Interesting tidbit there of around 1,000 hospitalized COVID patients. Fever was present in 44 of them at hospital admission, but developed in 89% of them during their hospital course. So fever is one of those things that should really raise our suspicion for this. In keeping with time, because I know that the hour is running long and we have a lot more that we want to share with you, I want to just keep moving along. One interesting thing you may have heard about in the literature is something called COVID toes. If you've heard about this, this is similar to pernio or Chilibrands, which is a condition where the blood vessels get inflamed and it's irritated by cold temperatures. So another one of these weird systemic things that we're seeing with COVID, and there's a whole list of other illnesses that's coming along. Asa, I'm going to turn it back over to you next to talk very briefly about both the infection and the cytokine storm, so we can keep this moving.
Absolutely. So next question, how does SARS-CoV-2 cause infection? So first off, the origin of SARS-CoV-2 is still being investigated. SARS-CoV-1 and the MERS coronavirus were both believed to have resulted from zoonotic spread from the bat population. So while the coronaviruses have likely evolved over thousands of years being confined to the bat population, at least in these two, intermediate mammalian hosts, for example, the cat type of cat in SARS-CoV-1 and the dromedary camels, at least in the case of MERS, have been implicated and likely have played a role in ultimately having the transmission of those coronaviruses to humans. So now we get to humans. So when we're in humans, the coronavirus is likely to cause infection by binding to what we call the angiotensin converting 2 enzyme, or the ACE2 enzyme receptor, which is expressed on a multitude of cells. And that's why you see such, or one of the reasons why you see such varied presentations and organ implications that patients are affected with. So for example, the lungs, specifically the type 2 alveolar cells. So that's why it has a real predilection for the lungs. It could cause the devastating pneumonia that we see with these patients. The intestines, which helps explain why diarrhea is a symptom with these patients, and also the kidneys and blood vessels. So those are just the ones in which this ACE2 receptor is expressed, and why this virus is able to basically get into and infiltrate those type of organs. All right, so moving along, I can certainly handle the next question, or Matt, do you want to take it?
Keep going. Yeah, so you're on a roll. It's good.
Okay. So cytokine storm is something else that we've probably all heard about, and this tends to occur in patients that present with the most severe disease. So essentially, cytokine storm leads to the deterioration of patients dealing with various respiratory viruses. We've seen it with SARS-CoV-1, we see it with influenza, the different types of influenza, and essentially it's a release of inflammatory markers that initiates this feedback loop that leads to respiratory distress, multi-system organ failure, and ultimately death. The cardinal or the key clinical features of cytokine storm tend to be basically an unremitting fever. So just the fever stays persistent. It may go down or away with Tylenol, then it comes right back up. Cytopenias, meaning the cell lines in the patients are all depleted. Hyperferritinemia, which is a marker of inflammation, increased ferritin levels, and in worsening and progressive lung involvement. So patients with severe COVID-19, and this is a quote from the literature, express excessive activated immune response. And this excessive immune response is ultimately what causes their deterioration. Again, you may have heard it in the literature in the mainstream media. Some of the therapeutics are not actually targeting the SARS-CoV-2 virus, but are actually targeting the person's own inflammatory markers to help get this cytokine storm under control. So in one sense, you're trying to treat the virus with therapeutics, and in another, you're trying just to deal with this cytokine storm that a percentage of the sickest patients can present with. All right, so Matt, I can either do the next one, or if you want to handle it, it's totally up to you.
I think the next question is about thrombotic risk. So Asa, I'll let you keep going,
sure.
And then we'll keep moving along here.
Great. So another thing that we see frequently asked in the literature and discussed in the mainstream media is whether or not these patients that are diagnosed with COVID-19 face an increased thrombotic risk or an increased risk of developing blood clots, whether that be in their extremities or in their lungs or in their brain. So to start, I think it's important to understand that the available data on thrombotic risks are quite limited, both in number and methodologically, and is largely based on case series. And the main reason for that is often these patients are too unstable to even send for imaging or diagnostic tests that could find clots. They're that unstable and that sick in our ICUs. However, with that said, the data out there for increased thrombotic risk is sufficient enough to recommend prophylaxis, so treating all hospitalized patients with COVID-19 with the intent to prevent clots, any type of blood clot, provided there is no contraindication. Something that's a little bit more controversial among clinicians is whether or not to treat patients with a therapeutic dose of anticoagulation, assuming that a clot has developed in the sickest of the patients if you are unable to get imaging to definitively diagnose it because they are too unstable to move. Because the thought is that some of these really, really sick patients, or patients that have been doing okay and then all of a sudden start to decline, may have developed thrombuses, again, in their lungs, or even microvascular thrombi that lead to their clinical deterioration, and starting them on treatment doses of anticoagulation could prove helpful. Moving to the next slide, I thought this was particularly interesting. Some of you may recognize this study it's not a study, actually, it's a case report out of the New England Journal of Medicine, where they looked at patients from March 23rd to April 7th, in particular 5 patients under the age of 50 who presented with new onset symptoms of a large vessel ischemic stroke. All of these patients tested positive for COVID-19. Of note, the COVID-19 symptomatology was not their primary reason of presentation. It was the major stroke symptoms. And even more telling is if you look over an average 2-week period, over the course of a year, on average, only 0.73 patients that were younger than 50 years of age presented with a large vessel stroke, compared with these 5 patients which presented over the 2-week period from March 23rd to April 7th. So that should really remind us as EMS clinicians to maintain a heightened index of suspicion for stroke presentations and patients who you would otherwise not expect to have strokes, for example, those that are young and otherwise healthy. So Matt, why don't you take the next question and discuss proning?
Well, thanks, Asa, and that's a great summary. Many of us have heard the term proning. What does it mean? What does it mean to prone a patient? Well, proning is something that Dr. Barinholtz and the ICU colleagues have done for many years with certain types of patients. And in essence, it's rolling someone onto their belly or into the prone position. And we believe that the proposed physiologic benefit for this has to do with changing, it's about gravity, and it's about the pressure that's on various parts of the lungs, and helps shift some of the fluid. As Asa mentioned earlier, part of the problem with this illness is the amount of fluid that collects in the alveolar level, and by shifting that fluid around, we can improve oxygenation and or aeration to part of the lungs, and even have them help clear their secretions. There's been increasing amounts of science and review about this, looking at the prone position and showing that in some cases it's actually likely to help reduce mortality or improve survival in patients with severe lung disease or severe acute respiratory distress syndrome, which is the dreaded complication from COVID. When they looked at around 600 or so COVID-19 patients, they found a significant effect on the awake prone position in terms of its ability to help with oxygenation. Just a point, at the current juncture where we're at right now in Maryland EMS and in protocols, we are not advocating for proning the patients in the 911 setting. But what you may see, depending upon what happens and how this plays out over the next 6 months, if people are home and they're getting worse and worse, they may themselves put themselves in this position, not because they heard our awesome webinar tonight, but because it may be easier for them to breathe. So it may become a position of comfort for them to breathe. And that's functionally different. But we're not advocating or telling you that we should initiate proning on patients as part of your hypoxia treatment. This is what it looks like. You can get an idea for some of the challenges we might face with trying to transport a patient in the prone position. And in general, transporting patients in 911 in a prone position is usually not supportive. There may be some evolution of this in the months to come, so we thought it would be beneficial for you to hear about. You know, what would I say if you're having trouble with someone with severe hypoxia? First of all, if they're conscious, they're probably going to want to sit up. So sitting them up is a good thing to do, or even on their side might help as well. But just wanted you to be familiar with the term prone and proning. Depending upon what happens in the months to come as the second wave of the pandemic hits, you may see this happening in ERs as you're bringing in other patients. So Asa, can we very quickly take a minute and review the highlights of some of the changes for ACLS and BLS care for these patients from AHA? I'll turn that back to you.
Yep, absolutely. So as you pointed out, the AHA has published some recent changes to BLS and ALS for PUI patients or those with confirmed COVID-19. So these interim guidance that was published by the AHA is to help guide our EMS clinicians and other rescuers in the treatment of victims of cardiac arrest with suspected or confirmed COVID-19. So why? Because CPR involves performing numerous aerosol generating procedures, including chest compressions, positive pressure ventilations, and establishing an advanced airway. So as we move to the next slide, you'll see some of these changes that were proposed. So first of all, category number 1 is to reduce provider exposure. So this is all the stuff we've really already talked about. So don your PPE before entering the room or the scene. limit the number of personnel that are within that 6-foot radius of the patient. Always consider mechanical CPR devices for adult and adolescent resuscitation who meets the height and weight requirements. And clearly communicate to any arriving EMS clinicians on scene your concern for possible COVID-19 status of the patient that you're working on. As we move to the next slide, this goes over prioritizing oxygenation and ventilation strategies with lower aerosolization risk. So first and foremost, we must be using HEPA filters for all ventilations, certainly if it's available, and you could see a picture of an example of one of them on the top right of your screen. If we are going to intubate, we should be intubating early. The most experienced clinician should be doing the intubation, and we should be using video laryngoscopy to all of these to maximize our first pass success, which is what we want to emphasize. A departure from what we've all been teaching recently is to pause chest compressions during the intubation process. And again, I just want to emphasize that as a departure, obviously, from our minimally interrupted high performance CPR in which we do not pause for intubation. In these cases, we do pause chest compressions in order to intubate. So I'll just have Matt advance the next one so you can see. So for adults, again, you can consider passive oxygenation with a non-rebreather mask as an alternative to a bag valve mask for a short duration, especially if you're finding you're unable to get a seal. So again, the HEPA filter is good for limiting transmission of viral particles, but that doesn't really do anything if you're essentially spewing out viral particles from around the side of the mask if you don't have a good mask seal. So in those cases, definitely consider passive oxygenation via a non-rebreather mask at 15 liters per minute over the patient. Again, if there's going to be a delay in intubation, again, go back to your jurisdictional protocols and policy, but you can also consider a supraglottic airway, with the caveat being the supraglottic airway needs to be placed appropriately. An inappropriately or an unseated supraglottic airway can again increase the risk of spewing viral particles to all of the rescuers on scene. Lastly, in terms of the AHA guidelines, we'll move on to the final slide here. So while the outcomes for cardiac arrest and COVID-19 patients are yet unknown, we suspect the mortality for these critically ill patients are going to continue to be very high and just going to increase with increasing age and comorbidities. With that said, this is a good opportunity to make sure that we all review our departmental policies for termination of resuscitation, and that we always address goals of care and review the most of patients in whom we are treating for cardiac arrest. So hopefully that was a quick but effective summary of the new guidelines put out by AHA. Matt, I'll turn it over to you for the next question.
Thanks, Asa. That's a great summary. Now, one of the things that we want to spend a few minutes talking about in particular is dealing with the respiratory distress patient, because the messaging that's come out has really put us in a bit of a quagmire, because we've become incredibly dependent in EMS on positive pressure ventilation for our patients in respiratory distress. But we know that one of the things we need to do is minimize how we aerosolize the viral particles, or how we get them sprayed into the air. So some strategies that should be considered: meter dose inhalers with spacers looks something like this, rather than giving nebulized albuterol if they're available. Okay, that's a big if they're available. All right. The other thing that some jurisdictions are starting to do is to put the neb mask, the nebulizer, in line with the CPAP mask, using the CPAP mask and the excellent seal that that foam mask can maintain around the face with a viral filter on the tail end. So we're really minimizing what's being aerosolized. Again, that requires logistics and supply and requires forethought ahead of time. May not always be possible and may not always be the right thing to do if the patient is not in severe distress. But if the patient is in extremis, you may have to go to positive pressure ventilation. That's okay. You're wearing a mask, you're wearing your N95, but we don't want to do that routinely unless that patient is in severe distress. I would also add that we've shifted our kind of clinical concept of operations in Maryland EMS and across the country to use more intramuscular routes of medication over intranasal delivery. So whether that's IM naloxone, or whether we're talking about giving maybe even IM terbutaline, which is an oldie but a goodie, to the respiratory distress patients. Anything we can do to minimize the amount of aerosolization. Additional considerations, we want to think about the oxygenation that we're going to provide to people in an escalating manner. So if we get there and they're in mild distress but they're hypoxic, we start them on a nasal cannula, as you can see in the left-hand picture there. If they're getting worse and worse, we may have to upgrade them to a face mask. And then if they continue to deteriorate, we may have to consider more aggressive non-invasive ventilation. If we're going to use CPAP, we really need to have a viral filter on it. But again, we're not saying don't never, ever use CPAP. What we're saying is that we need to keep that for the most dire of circumstances. And please, everyone, if you're going to initiate CPAP on a patient nowadays, because they are going to be a PUI by definition, you have to let the hospital know ahead of time. But we only want to do that in the most dire of circumstances. We don't want to do is let you watch someone go into respiratory arrest because you're afraid to initiate CPAP. We're not advocating for that. Neither myself or any of the medical directors or Dr. Chismar would say that. We want you to use the tool if you need it, but we don't want to use it if it's not needed. Some other things to consider: viral filters on the ET tubes, pre-assembled ahead of time. So we can have that, not pre-assembled, but before we start ventilating the patient, put it on first. And that way we can avoid a break in the mask seal. So those are some other considerations there. I think this is just a quick summary slide for the management that we are using in the hospital side for COVID-19 patients who are hypoxic. You know, as you can see, for the ALS clinicians online, we've moved up intubation pretty high up, which is, you know, if we need to do, the advocacy now is for early intubation. If we cannot maintain their SATs, if they're worsening hypoxia. Again, with a preference towards video laryngoscopy. Now, if they're maintaining their SATs on supplemental O2 and we can closely watch it, that's fine. By the way, everybody, what we are considering an acceptable SAT for these patients is anything over 92%. So just because you can't get them above 92, we all strive for 100 because we're all type A personalities. But the 92 or higher is really what we're going for here. We're going to keep moving because we're already at the top of the hour. We're going to skip over. Asa, would you like to do this question quickly, or did you want to touch on this, the current therapeutic options, or what's your preference here?
Yeah, I could talk about this quickly. Okay. So there are a couple therapeutics out there that many of you have probably heard of, and we want you guys to have just some frame of reference as to what they are. So you'll see the summary list: Kaletra, hydroxychloroquine. Some are combining hydroxychloroquine and zithromycin, remdesivir, and convalescent plasma. So going to the next slide, one of the first drugs that was looked at for this was Kaletra. This is an HIV medication, and this is actually done in a randomized trial, which we in medicine consider to be the gold standard. Bottom line, no benefit. No benefit compared to those who were given Kaletra, to those that were given standard of care. So you will no longer be hearing of Kaletra as a therapeutic option for COVID. Next slide, we'll look at hydroxychloroquine. Obviously, this is something that we've heard quite a bit about recently in the literature. So for hydroxychloroquine, again, there's been no definitive data available on the effectiveness or comparative effectiveness of either hydroxychloroquine or chloroquine for the treatment of COVID. A lot of the early studies, and Matt, I'll just have you advance to the next slide for a sec. A lot of the early studies looking at hydroxychloroquine and even azithromycin came from very small, non-randomized observational studies, which we in medicine don't really consider to be the decision-making studies. So in addition to not having good data to show benefit, there is data which shows there is toxicity, in particular cardiac toxicity, specifically prolonging the QT interval. So based on that, at this point, no definitive evidence suggesting hydroxychloroquine. It is being utilized in some studies and can be done that way, provided it's done and monitored by a physician. And with azithromycin, there's certainly no evidence to suggest, and there are no recommendations of combining azithromycin with hydroxychloroquine. All right, moving to the next slide. Remdesivir is a medication most of you have probably heard of by now. This initially came to the market with activity against Ebola and has actually showed some inhibitory effects of SARS-CoV-2 in vitro and SARS-CoV-1 in animal models, as well as SARS-CoV-2. So that basically led to testing in humans. And recently, going on to the next slide, the FDA, as of April 29th, issued a statement saying that based on randomized, double-blinded, placebo-controlled trial that was conducted by the National Institute of Allergy and Infectious Disease, and then a secondary trial that was done by Gilead Pharmaceutical that was done to evaluate both the duration and the dose of remdesivir, that it's reasonable to assume now that the potential benefit of this drug could outweigh potential risks. And therefore, that's why we're seeing this drug utilized in patients, often in studies within our hospital setting. Lastly, for therapeutics, one thing you may have heard of on the next slide is convalescent plasma. Again, this is not a new concept. This is essentially taking survivors' antibodies, or their plasma, and separating their antibodies from red blood cells and essentially transfusing it into somebody with the disease, whether it's significant or minor disease. Now, this is something that's been utilized prior. It's been utilized to combat a wide variety of diseases: measles, SARS, Ebola, H1N1, polio, and is felt to be a possible strategy for keeping this virus at bay until an effective, reproducible, and upscalable vaccine has been developed. So I know that was a lot altogether, but we wanted to make sure you guys have some visibility on the current management of these patients. So Matt, I'll turn it back over to you for the next question.
Thanks, Asa. So one very quick question that we've gotten was, we heard, or it's been said that non-steroidal anti-inflammatory medicine should be avoided in COVID-19 patients. Just very quickly, what's that all about? Well, it's about this tweet that you can see here on the bottom right-hand corner of your screen with some data that initially came out in Europe saying that this stuff could, that non-steroidal medicines could actually cause harm, and there's some plausibility to it. Because of the way that the angiotensin converting enzyme is upregulated in the body. The bottom line, though, is that the literature hasn't really supported this, and there are no clinical studies to date that have been performed. But because of this potential, most clinicians are avoiding the use of non-steroidal anti-inflammatory medicines, such as ibuprofen or Motrin or ketorolac in the COVID patients. And, and other means for antipyretic management, such as Tylenol or cooling blankets and ice packs are preferred. So just wanted you to know about that. Asa, can you very quickly talk about where we're at with vaccine development and what the landscape looks like?
Absolutely. So we all know that scientists are working as quickly as possible to develop a vaccine. But realistically, this is felt to be at least probably a year away. Now, to give you some perspective, vaccine development takes, if you're lucky, 3 to 5 years to get through all the different steps and all the different phases. And once you actually get a vaccine that has demonstrated the appropriate protective immune response in the individual, it's going to be necessary to upscale production. And the reason why this isn't just, okay, you give it to somebody to see if it works, like another type of therapeutic, like an antibiotic, is because you have to observe the immune response over time. And for efficacy studies, you have to have enough people naturally exposed to the virus to determine really whether the vaccine prevents disease. So those are really the main reasons why this is going to take a while and is not just ready to use like these other therapeutics that I just spoke about prior. So Matt, I'll turn it over to you for the last question.
Thanks. And the last question has to do, guys, with this condition that we call MISC, and what we want you to know about it. So MISC is a condition that's affecting some children, and we just want to give you a quick overview. The majority of children who who have COVID have a very relatively mild course of illness. However, there's a subgroup of them that can develop a systemic syndrome or illness, and it may lack respiratory symptoms, it may not even have a fever. This syndrome is referred to as the multi-system inflammatory syndrome, or MIS-C. What we're seeing, or what's being described right now, is that it's developing from 2 to 6 weeks after infection with COVID-19. And it tends to affect mostly young, healthy children and teenagers. You may have heard some similarities with the Kawasaki disease, and there's some overlap there. Kawasaki disease has to do with fever and conjunctivitis and vasculitis and some other symptoms, including sepsis. And understand that we really think this is a complex immune system response that some children will get. Now, if you look on the right-hand side of your screen, you can see some of the symptoms that are reported in these children: abdominal pain and vomiting, conjunctivitis, rashes, headache and confusion, poor peripheral perfusion, so like a prolonged cap refill time, changes in mental status, hypotension, respiratory failure, and in some cases even heart failure or death. Now, here's the challenge that we face. So these are pretty serious symptoms, and I'm sure if you walked in and saw on a call and saw a child who looks like that, you wouldn't think twice about transferring them to the hospital. However, the challenge that we face, everybody, with pediatrics, as we all know, is that kids compensate. Kids compensate and they hold on for as long as they can until they can't anymore, and then they crash on us. So you got to maintain extra vigilance about this, okay? A child that presents with tachycardia or other non-specific vague symptoms should make us think a little bit more about this, and we should be extra vigilant about looking for that underlying disease, right? Pay extra close attention to the vital signs. It's important, it's essential that you know the normal vital signs for the child, that the age range of the child you're taking care of, okay? And be especially sensitive and especially cautious about kids with low blood pressure and fast heart rates, okay? Because that could indicate to us this person is going down a very bad clinical course. And as I said a moment ago, remember, kids compensate for shock early on, and they do very well, and they kick up their heart rate, but then suddenly decompensate and deteriorate very quickly. And if you've never been on a call with a child who's deteriorated, I hope you never are, but if you have been, I'm sure you can empathize with what I'm saying. When looking at these children, when thinking about this, if we're thinking about possible MIS-C in a child, treat them like a PUI, please, okay? Use the same level of protection that you would for any other PUI. And of course, be sure to alert the receiving ED if you're having this. And just as a reminder, you can consult with a pediatric base station for further guidance if you think you're dealing with a child with vague or unclear symptoms and you're not sure if this is MIS-C early on. We acknowledge and we know that the hardest part of our jobs in EMS medicine is we see that patient for a very small set of time, and we have to make some very critical decisions. Guys, what I need to ask of you for these patients is be extra vigilant and avoid trying to say things like, oh, well, you can probably have them follow up with the pediatrician. That's not what we want to do here. That's not the message we're trying to send. So we need to be extra cautious with this stuff. This is an emerging syndrome, and more to follow. So maintain vigilance. There'll be more messaging, without doubt, coming out about this in the weeks and months ahead. Now, some final thoughts that we put together for you to end on this note before we roll into some questions and answers. First of all, we're seeing higher acuity patients. The patients that we're seeing now with COVID are sicker. Why is that? Well, it's probably for a couple of reasons, not the least of which is people are afraid to go to the hospital. They don't want to go to the hospital. And so they're staying home longer, and our overall acuity and call volume is getting more complicated, and these patients are getting sick in proportion to the volume of calls. So please do not talk patients out of going to the hospital. If they've activated 911 and they have any exam findings or abnormal vital signs, we shouldn't be in the business of talking these people out of 911. We've had multiple sentinel events across the state and locally where the next call back to that house is for an arrest, is for a cardiac arrest, because we're not actually helping them, even though we may think, oh, well, you're more, we're stay here, it's safer here at home. That's not actually the intent. Okay, some of these people will decompensate quickly. I just reviewed a case yesterday where the EMS crew did everything right. and the patient didn't want to go, and the patient looked good. They got a refusal. By the way, not a jurisdiction that's online tonight, but we did everything right. Patient presents at a hospital and had a very, very, very bad clinical course. Within 2 days was intubated and was deceased within 4 days. So we have to be extra careful about this stuff. The next thing I want you to know is I want you to trust your PPE and your equipment. I remember the first time I did a high angle rescue training, the instructor said to me, you have to trust your equipment or this is not going to work. Guys, the same is true here. Your N95s will provide you with the protection. The face mask, the eye protection, that's what you need to do to be safe. We want you to be wearing masks on all calls all the time. We still see EMS clinicians around the community coming into the EDs not wearing masks, and we're baffled. The risk is real, okay? Same thing for face coverings in the stations. I know it's an inconvenience, but you don't know who's going to be sick in 48 hours from now. And you don't know if you're going to be the one who's going to be sick. And guys, I have to tell you, one of the most difficult discussions I've had recently was with an EMS clinician who became symptomatic and knew that they weren't wearing a mask and really, really had a lot of emotion about the fact that they could have endangered their colleagues. And so we have a civic duty here. The next thing I want to touch on is please believe your pulse ox, okay? Some of these patients with COVID, particularly those who are having a deterioration in their status, they're phenomenally hypoxic. We're talking about pulse oxes or SATs in the 50s and 60s and 70s. Believe your pulse ox. If you're going to recheck it and check another one and they're both wrong, well, chances are that all 3 pulse oxes aren't broken or all 2 pulse oxes aren't broken. So we know that we see severe hypoxia with these patients. Excuse me, get them that O2, get on there and get them transported to the hospital. Couple more things. Heads on swivel. You gotta be aware of your surroundings and maintain situational awareness. What do I mean? I mean, we've spent the past hour talking about one viral syndrome and how it's really wreaked havoc on society and the normalcy as we know it. But there are a lot of secondary consequences to this. Okay, think about abuse, neglect, financial exploitation of the elderly. Think about domestic violence. Think about all the things that can happen when people have been home for so long now, and the societal shifts that we're seeing. Okay, please, along those lines, watch out for each other. Okay, I'm just going to say this: life is very stressful right now for everybody. All right. Watch out for each other, watch out for your colleagues, watch out for signs of the abnormal. They may manifest like signs of critical incident stress. It may not be critical incident stress or post-traumatic stress, but rather the stress response is what we want to be aware of. And if you see something, say something, okay? See something, say something, notify an EMS supervisor, notify someone in your leadership chain so we can get people the help that we need. There is a great degree of concern right now about mental health, wellness, and safety of our healthcare communities. You may have heard of the emergency physician in New York who committed suicide a few weeks ago. That anytime we deal with loss of life in our family, in our extended professional family, it's devastating. And we're not immune to having to have dealt with that locally in the past either. But this stuff is going to affect people in a variety of ways. And then lastly, okay, and not to end on a negative note, but I want you to know that we really believe another wave of COVID is coming. We really believe. Okay, that's what the evidence would say. That's a scientist, what the best data says. That's what we're forecasting for. And it's not a matter of when. It's not a matter of if, it's a matter of when. Okay, so we want you to be healthy. And we want you to be ready. We want you to be prepared. We want you to be clinically on the ball, okay? Because what we're doing right now is not entering a demobilization phase like we would do for most disasters, but we are maintaining a sustainment posture for how we can continue to operate like this for a little while longer to come. So with that, that wraps up our slide set. And Dr. Berholtz, I'm going to turn it back over to you. If we have any time left, we'll be happy to entertain some questions.
That's great. Thank you so much.
You didn't open the window.
So let's get our
Those things,
video back to
if
you
I
guys.
don't put it out in a
Those who
hill,
are not
viewers will
speaking,
still be
if
able
we
to
can
see you.
mute. See if I can find them. Perfect. Great. So why don't we do this via the chat? Oh, did you mute me? No, good. Why don't we do this via the chat? We're getting some thank yous. Well done, excellent. Thank you, thank you. Questions?
Okay, let's see. Just scrolling through here. Asa, can you see the questions on your end as well?
Yeah, just saying excellent. Thank you.
See a lot of people saying thank you, so thank you to everybody. We appreciate that.
Well, thank you guys for listening.
That was a great talk, really super comprehensive.
Thank you, and thank you for taking some time to listen and to help us share some information. So one question, and it looks like has come across, has been, please discuss what to do with masks that are used and are to be reused. Okay, thank you, Beth Phillipson, for that question. I'm going to give you my best, I don't know the answer to that, which is stay tuned for more, because I suspect there will be formal guidance coming up from the department about the process that will be followed and implemented at the station level for where those masks are to be collected or placed and collected and stuff like that. So stay tuned for more. And one thing you should know about Asa and I is we will never lie to you guys. If we don't know something, we'll just say we don't know. Beth, I don't know. So we'll follow up on that and try to get you an answer. Oh, Beth clarifies, she doesn't mean for the ones that are being disinfected. So I suppose, again, we'll make sure that the guidance document and the policy documents are clear. And I know Chief Shenning and some of the leadership team are online as well to talk about what the process is going to be. So taking your mask off in between calls, and what do you do on a call-by-call basis if you're taking your mask off? Generally speaking, most recommendations are to use some type of dry storage condition. I will tell you, in the ER, we're using brown paper bags, and there are jurisdictions that are doing that too. It's incredibly low tech, but it keeps the mask dry, and that's going to be increasingly important for us as we enter our Maryland, Florida summer season. So that's what I got for you on that. Asa, anything you want to add to that?
Nope, totally agree. Brown paper bag works really well for storage. Put your name on it. You know, when you take it off, obviously check it to make sure it's not soiled, make sure it's fitting, make sure the elastic band is still in place. And if all that is good, you know, doff it appropriately, put it in the brown paper bag, make sure it's labeled, like I said, with your name, and store it in there in between your calls.
Great. All right, I don't see any other questions on the chat box. Well, you know, we certainly thank you guys so much for tuning in and listening to us go on and on for the past hour and 20 minutes. We hope you got something out of it. You know, we will try to, as we were saying amongst us before the call started, you know, one of the silver linings of this situation and this new normal with social distancing is being able to leverage technology like this to do exactly what we're doing tonight. So in a bizarre way, if this can bring us closer together, then that's one of the good things that will come out of an awfully bad situation. Asa, do you have any final thoughts on your end?
No, just again, like I started, thank you very much for giving us the opportunity to present this, what we feel to be very important information to you guys. Obviously, we're local. We are medical directors of a neighboring jurisdiction. You can find us if there are questions, concerns, even after this webinar ends. Please don't hesitate to reach out, and look forward to hearing from you.
Great.
Thank you so much, you guys. I super appreciate it. Super generous. Thanks for taking care of our pre-hospital providers.
Thank you.
Right. What an amazing group. Don't forget, everyone, if you haven't signed in, the link actually is sent around a couple of times in the chat. And I think I am going to hang out just to make sure that everyone has been able to sign in. But I think that's the end. Thank you so much, you guys. I super appreciate it. Please take care of yourself and stay well.